I'm sitting in for Dr. Kugler today on an overview of the knee, and it seems reasonable for us to address the knee anteriorly. It's way important to know the knee because it's the largest joint in the body, and the epidemiological studies indicate that in most sports, or in many contact and collision sports, the knee is the most frequently injured joint of the body. So you need to be a student of the knee. And our tendency is to start anteriorly. That's how we meet people when they're in shorts, when you're at the beach. You encounter lots of anterior knees. I thought maybe we'd start posteriorly and appreciate the fact that the muscles of that originate down in the crurus, which is the calf, the common language is the calf, the gastrocnemius, medial and lateral heads cross the knee posterior to the frontal axis, the medial lateral axis, and therefore when concentric contraction occurs in the gastrocnemius, flexion results. So here's the axis of rotation, here's the contraction, and knee flexion results. When we dissect, this is called a transection and a reflection of the gastrocnemius, so it would be cut through the belly, laid back this way. We come to the deep muscle that fills the popliteal fossa. The popliteus muscle is called the upside down muscle. The muscle belly is inferior. This is a little bit different than architecture for a lot of muscles. Muscle belly is here, and the lateral insertion is on the epicondyle. So the popliteus courses right here and actually comes under the cover of the lateral collateral ligament. Lateral epicondyle, fibular head, LCL attaches there, and the relationship of the popliteal tendon, the superior tendon, is there's the attachment of the tendon, and it's under the cover of that collateral ligament. And so if you've got a client who has a lateral epicondylitis, you have to determine whether it's a sprained LCL or a tendonitis or strain of the popliteus tendon. Runners who do a lot of downhill training, a lot of eccentric loading of the popliteus, can develop an overuse inflammatory condition in the lateral epicondyle. I think it's worthwhile to say at this point, when your leg or the people you're working with, when you're working with them in terms of topographical anatomy, maybe these prominences of bone are not readily available to you. So my encouragement is that you do a flat-handed sweep inferior to superior, and you feel for these bony prominences. The fibular head and the lateral epicondyle are in the frontal plane. So if you divide this part of the leg between anterior and posterior, they're in that midline. So flat-handed sweep to the apex of the fibular head, flat-handed sweep to the apex of the epicondyle. And what we need to know, be reminded, is that the knee joint has 2 degrees of freedom, flexes and rotates. And this is what I want you to think of. In an open kinetic chain, all muscles that result in rotation are internal rotators, except for the biceps femoris. I'm going to talk to you about that a little bit more, either at the end of this video or in another video. And so the popliteus, think about this. If this is the anchoring point where the popliteus attaches to the lateral epicondyle, when this contracts, the popliteus contracts concentrically, it internally rotates the lower leg. I'm going to call it the crurus. The tibia and the fibula internally rotate as a result of this concentric contraction of the popliteus. And then let's go lateral. It just so happens that this little remnant here is the extension of the popliteus, so don't be thrown off by that. And then if we move into the lateral aspect of the knee, there is, and this is a flat-handed sweep, in the anterior lateral portion of the tibia, you encounter the tubercle of Gerty. This is the distal attachment point for the iliotibial band. At the knee, the iliotibial band serves a stabilizing function, or a ligamentous function, in the lateral knee. When there are forces that would tend to take the knee into valgus, where the tibia gets here and the femur gets here, there's opening or a dislocation force in the lateral knee. The LCL, which is this spring, and the iliotibial band, which is this remnant of a band on the tubercle of Gerty, tether those two together, because it's not good for that knee to open this way. It causes compressive forces on this meniscus and distraction force on this meniscus, the lateral meniscus. And then obviously anteriorly, the tibial tuberosity is the attachment site for the quad tendon. Appreciate the fact that the three vastus muscles and the rectus femoris converge into a conjoined tendon, crosses the knee anterior to the frontal axis, so it's that group is extenders. And the patella is built into the tendon. Here's the patella, and that tendon interfaces, is woven into the periosteum of the patella, and that helps hold that patella in place. But in addition to that, and I'll just let you know that there are patellar collateral ligaments, medial and lateral, that keep the patella from just wandering around to the posterior aspect or the medial or lateral aspect. The collateral ligaments. I'll have a better illustration of that in just a second. And then the muscles that have inferior attachment medially on the tibia are the three muscles of the pes anserine. There it is, pes, foot, anserine, goose. This is the goose's foot. And these muscles are the sartorius, which courses from way lateral to way medial, longest muscle in your body. Just dissected it Friday with a couple of students. Very impressive in terms of its length, can contract 40% of its total length. Not a very large muscle, about this big, so it doesn't generate a lot of force, but it causes movement in three planes. We'll talk about that another time. And then the gracilis, the superior attachment of the gracilis, is on the pubis, and the semitendinosus, which courses from the ischial tuberosity into this flare of the tibia at the pes anserine. And then obviously a major medial stabilizers, the medial collateral ligament, way more substantial than the lateral collateral ligament. It actually has, it's a thickening of the ligamentous capsule medially, and because it's thickened, it gets the name of a ligament. An interesting feature of this is that the deep portion of the MCL is attached to the medial meniscus. And so if there is hypervalgus, I think I may have messed up when I talked to you over here. I think I described hypervarus. Hypervalgus is where the lower leg would get a long ways away from the midline of the body. Oh, yeah. So forgive me for misspeaking over here. When the lower leg goes to the midline, that would be hypervarus. When the lower leg goes away from the midline, that's hypervalgus. Okay, sorry to misspeak there. But if this medial joint line opens, the medial meniscus is vulnerable to a distraction force because it's attached to this ligament that's being challenged, and the lateral meniscus gets compressed and can be damaged. Okay, and yeah. So that's an overview of the anatomy of the knee.